Hello everyone, and today on your Applied Bacteriology lecture series we'll be talking about upper respiratory tract infections. The learning objectives for the upper respiratory tract infection section include being able to distinguish between a viral and a bacterial upper respiratory tract infection, discuss the different treatment options, so for bacterial which antibiotics would be appropriate, and for the viral infections do you use antivirals or do you treat them mainly supportively? Case 1. You receive a message from one of your long-standing clinic patients. He's a 72-year-old man with non-insulin dependent diabetes and untreated hypertension requesting antibiotics for a sinus infection. His diabetes is diet controlled with an A1C of 9.4. He refuses to take medication for his diabetes because he believes diet control is sufficient. At his last 8 outpatient visits, his blood pressure has ranged anywhere from the systolics to 140s to 160s. He has refused any antihypertensive medication because he asserts the elevated readings are due to white coat hypertension. His home blood pressure readings are in a similar range. He has previously explained that he is always aggravated when he checks his blood pressure at home. In general, it is more likely that his symptoms of acute rhinosinusitis are caused by a bacteria or a virus. It's most likely his symptoms are related to a viral infection. Viral upper respiratory tract infections actually count for about 90 to 98% of the rhinosinusitis infections, better known as the common cold. The average person actually has about 2 to 4 of these a year, which are likely due to a virus. Risk factors include physiological stress, poor hand hygiene, and the reason it's important to distinguish between the two is because the treatment will be different between the two. Unwarranted antibiotics given for a viral infection can lead to unnecessary side effects and antibiotic resistance. Initial signs and symptoms include nasal congestion, fatigue, clear nasal discharge, sneezing, body aches, sore throat for the first few days. The symptoms typically evolve into a purulent nasal discharge, and this is when patients typically think it's bacterial and they need antibiotics. However, this is actually just the recruitment of leukocytes, and it does not indicate a bacterial infection is present. These symptoms usually peak about 2 to 3 days and resolve completely in about 5 to 10 days. However, it is important to note that if a patient has a persistent cough for weeks, this is classified as bronchitis. Going back to our patient, we call him back to further discuss the symptoms and tease out if we think this is a bacterial versus viral infection. Key things to identify are duration of symptoms that we previously discussed. How long has it been going on? Also, take note, how sick is this patient? Does he report a really high fever, typically greater than 100.2? Does he have a lot of facial pain or pressure? And lastly, did he say that he started to feel better and then he got drastically worse? This is better known as a double sickening. If the patient describes any of the above, it is more likely a bacterial infection rather than a virus. The patient's symptoms didn't fit with a bacterial infection, and we diagnosed him with a viral rhinosinusitis. The treatment is supportive. The majority of these can be found over the counter. You can recommend NSAIDs or acetaminophen, sodium chloride nasal sprays, which will help thin the crusty mucus or nasal discharges, saline irrigation, better known as the neti pot. Studies show minimal benefit, and it's important to abide by the instructions in these neti pots because there are case reports that patients can get anemic infections from these, which cause encephalitis with the pathogen known as Naegleria fowleri. Nasal decongestants can be used, such as oxymetazoline, that's better known as Afrin. However, please educate the patients to not overuse it, as it can cause rebound congestion, better known as rhinitis medicamentosa. Oral decongestants include pseudoephedrine. However, be aware these side effects include insomnia, hypertension, and dizziness. Intranasal corticosteroids actually show no benefit unless there is an allergic component. However, the IDSA guidelines do say you can give this as needed to help alleviate symptoms. Case 2. You are asked to evaluate a nursing home resident. He is a 78-year-old man with diabetes and moderate dementia. He has a mild upper respiratory tract infection symptoms last week, but now has developed a fever to 102.2 Fahrenheit and is lethargic. He answers yes to most questions asked of him, including, "Where are we?" On exam, he is congested and seems to have tenderness over his frontal and maxillary sinuses. His right tympanic membrane appears full, though not inflamed. Given the clinical presentation of double sickening, having a mild cold that has become noticeably worse instead of getting better, you decide to treat him for an acute bacterial rhinosinusitis infection. What are the likely bacterial pathogens? The most common bacterial pathogens causing upper respiratory tract infections include your Streptococcus pneumoniae, which I've placed a slide here in the middle. As you know, Streptococcus stains purple, and you can see the purple change, which identify as your Streptococcus pneumoniae, Haemophilus influenza, Moraxella catarrhalis, and your Staphylococcus aureus. Most common viral pathogens include your rhinovirus, your coronavirus, not the SARS-CoV-2, adenovirus, and your parainfluenza virus. Now, knowing the most common bacterial etiologies, begin to think of empiric antibiotic coverage for these organisms. When discussing treatment options for your bacterial rhinosinusitis, first-line therapy currently is the high-dose amoxicillin clavulanic acid, which is better known as your Augmentin. That's the 2 grams of amoxicillin and 125 milligrams of the clavulanic acid twice daily for 5 to 7 days. The high-dose amoxicillin alone is a reasonable choice. However, the IDSA guidelines are actually recommending the amoxicillin clavulanic acid due to acquired resistance from the H. influenza bacteria to amoxicillin and also the inherent resistance of Moraxella to amoxicillin alone. So another consideration to take into is patients who are penicillin allergic. So when dealing with a penicillin allergy, it's important to discuss with the patient first to ensure that it actually is a true penicillin allergy. And if they fulfill that criteria, then the first line choice for someone who is penicillin allergic is your doxycycline, 100 milligrams, once in the morning, once at night, for 5 to 7 days. This medication, when you do prescribe this medication, it's important to review the side effects. So like pill esophagitis. So make sure that the individual is taking a full glass of water when they take their doxycycline and they don't immediately lay flat. And also counsel them about avoiding direct sunlight, as the side effect of photosensitivity is a risk with these patients taking doxycycline. Second line therapy for penicillin allergic patients. So for some reason they can't tolerate the doxycycline, or they'd rather not have the doxycycline, you can use your respiratory fluoroquinolones, and those are your levofloxacin 500 milligrams daily or your moxifloxacin 400 milligrams daily, also with the same duration of 5 to 7 days. However, these are second line because of the growing resistance of bacterial agents to your fluoroquinolones. And then you also have to worry about the other side effects of Achilles tendon rupture, and these medications can prolong your QT as well. So say that you've treated your patient 5 to 7 days, you've chosen the appropriate antibiotic, and they fail to improve or they're getting worse. It's important to consider, certain complications. So patients can have local extension of their infection, so into the nearby bony structures of the intracranial cavity, or to the superficial structures around the orbit, known as orbital cellulitis. The bacteria can spread to the central nervous system and cause an encephalitis, meningitis type picture. And the infection can also spread into your venous sinuses as well. And another consideration to take into account is, if they're not getting better, is maybe this is a fungal etiology. Is the patient immunocompromised? Is it a bone marrow transplant patient? And that would be something to consider as well. So I'll conclude the talk with this slide. I hope you have a better understanding of how to approach someone complaining of your upper respiratory tract infection, and how to decide whether this is more likely a viral infection or bacterial, and how to effectively treat the patient if it's bacterial, and then how to, different therapies you can offer to support the individual to get through their symptoms if it is indeed a viral infection. Key takeaway points for this lecture include being able to distinguish between a bacterial and viral upper respiratory tract infection, know the common presentation for an acute upper respiratory tract infection, know the common pathogens causing either a viral or a bacterial upper respiratory tract infection, be able to identify appropriate supportive care management for a viral infection, and then be able to determine the appropriate antibiotic choice and duration for a bacterial infection. And as a reminder, I encourage you all to review the IDSA guidelines for a more detailed description of the material covered in this lecture. I've provided the link at the bottom of the review slide. Thank you.